The next procedure we're going to talk about is the chest tube. It's a given that when you do these procedures on the chest that we're going to prep widely. We're going to prep from the base of the neck all the way down to the pubic bone and then from side to side on the chest. Once again, if you recall, the landmarks for the chest tube are going to be the 4th or 5th intercostal space. And we use in the male the nipple, or in the female the inframammary crease. And in patients in whom this anatomy is a little bit distorted, you can also take your hand and put it in the axilla, and the bottom of your hand is about the 4th or 5th intercostal space. If the patient is moribund or comatose, you probably don't need to use local anesthesia, but it's probably a good idea to use local anesthesia in patients who are otherwise conscious. The chest tube procedure is something that every physician needs to know how and master, because this is something that you can save a life with. In fact, 85% of all penetrating trauma to the chest and blunt trauma injuries can be treated with just a chest tube alone. Indications for a chest tube are going to be such things as a simple pneumothorax, a tension pneumothorax, or a hemothorax. If you have a tension pneumothorax, you're going to preclude the chest tube by putting in the needle thoracentesis, which we taught you earlier. Obviously, you want to make sure that you prep this area widely. You're going to once again reaffirm your anatomical landmarks, which are going to be the 4th or 5th intercostal space, approximately right here. If this patient is somewhat aware, it's good to put in some local anesthesia, but we'll assume that this patient is comatose and doesn't need it at this time. If your patient is awake or conscious, it's a good idea to use some local anesthesia, as this can be a very painful procedure. Generally, we like to use some lidocaine with epinephrine, and we're going to infiltrate the skin over the area of the landmark, which is about the 4th or 5th intercostal space, just anterior to the mid-axillary line. I'm going to raise a little bit of wheel. I usually like to go down right on top of the rib that I'm going to be making my incision over. I'm then going to take a 10 blade, make an incision approximately 2 to 2.5 centimeters in length over the rib, right down onto that rib. Now, what I like to do is actually verify I'm on top of that rib. I can feel that rib underneath my finger here. I'm then going to take my anesthesia and infiltrate a little bit more anesthesia on top of the rib. The other key point here is you want to go on top of the rib, not under the rib, because the neurovascular bundle is under the rib and you'll cause intercostal bleeding if you do that. The other key here is to use a large clamp. Because we're suspecting in trauma that there's blood, we always want to use a fairly large tube, at least a 36 French tube. And if you look at the chest tube has several holes in the end of it, and that last hole breaks this white line. This white line shows up on an x-ray, so if you look at an x-ray, you can tell where that last hole is in relationship to the skin. The other little trick here is that you want to make sure when you're putting this in for suspected blood is that you clamp the end of the chest tube, because if you stick this into the chest and there's blood in the chest, it's going to come out all over your shoes. So we've got our chest tube ready, we've got it clamped. Now we're going to go ahead and put our finger back on the bone and feel it. We now can feel the bone underneath our finger here. We're going to take another large clamp. You're going to go directly over the rib that you put your finger on a moment ago, and you're going to push up and over the rib and into the chest. And this maneuver requires a substantial amount of force if done properly. And you generally will feel a large pop. The thing here is in a young, healthy, muscular patient, this can require quite a bit of effort, and so don't feel nervous about pushing too hard. Once you've done this, you want to then spread, close your clamp a little bit, spread again. The idea is here you want to make a hole large enough that you can put both your finger in, first of all, and then this large tube once you're done. I now have a hole in the chest. The next step is to take and put my finger into the chest, confirm, number one, I'm in the chest. And in the patient, you should be able to feel the lung up against your finger. Also, the reason for putting your finger into the chest is to sweep your finger around inside the chest to make sure there's no lung adhesions with the lung stuck up against the chest. Because even if the patient has a pneumothorax, he can still have adhesions up against the chest wall, and you can cause additional damage to the lung if you don't sweep down these adhesions. So now we've confirmed we're in the chest. We can feel the lung under our finger. And now the next step is to actually insert the chest tube. So now there's a couple of different ways of doing that. You can actually try to put the tube in directly, but I think many people find it convenient to take your clamp, put it on the end of the chest tube, and then try to follow this track right back into the chest the same way you went before. You can see I'm going into the chest. There's the last hole. My goal now is to have this go in a posterior direction, laying along the back of the chest wall towards the apex. So that last hole's going into the chest, I'm advancing it, and I usually advance this till I feel a little bit of resistance. That tells me I'm bouncing off the apex, and then I pull back a slight amount, so this is 1 or 2 centimeters from the apex. Now that the chest tube's in place, we're going to go ahead and sew it in. Generally, you want to use at least an O silk. You're going to create a suture on either side of the incision. Taking a nice generous bite. The goal here is you're going to want to secure this tube in place so it doesn't get pulled out, particularly if this patient is going to be transferred somewhere else. You want to make sure you secure it firmly. So we're going to tie this down. And then we want to fix this firmly around the chest tube. The way I like to do this is to actually create a half hitch on one side of the tube, and then using the other suture create another half hitch, as you see, and then pull opposite on either side of those tubes so it now indents that tube. And while holding this under tension, I can now tie this down securely. And the tube is fixed to the chest wall and not likely to come out. We then cut the suture. And then the key point here to complete this is you need to hook this up to this underwater suction using this chest tube apparatus, collection apparatus. And this has been hooked to the wall with minus 20 millimeters of suction. We then take the end of this, plug it into the chest tube, release the clamp, and you should see either blood or air come out of this if you put this in for the right reason. At this juncture, you will now put a dressing on this and tape it to the patient's chest wall.